Well, good morning, everybody. I'm Mitch Brinks, Chair of Vision 2020 USA, and I'd like to welcome you to our annual World Sight Day Congressional Briefing. This annual Vision 2020 USA event is usually held in the Rayburn office building, but is being delivered virtually and fitting with our topic this year, addressing COVID-19 related healthcare challenges with stronger telehealth policy, the future of medicine. COVID-19 has showed us again how the health of Americans is really central to the future of our country. This recent threat, directly impacting solely our health, has undermined our entire industries, our national economy, required trillion-dollar emergency expenditures, a restructuring of our educational system, and altered the way we interact with each other around the world. This wake-up call may create an opportunity to rethink how we address healthcare. Acute events like this pandemic and long-running health access challenges that cause a steady drain on our national vitality await solutions. In the example of eye health, essentially we only deliver medical care for about half of Americans facing major blinding diseases. Only half of those with glaucoma know they have the disease through diagnosis, and about half of those with diabetes get the care they need to prevent blindness. I think it is time for us to bring our great national capacity to bear on this problem and think about addressing healthcare across populations. Our ever-advancing technological capacity can be fully utilized, but only with strong federal leadership, as will be discussed by our experts shortly. Before our two experts, Dr. Tony Cavellerano and Dr. Ingrid Zimmer-Galler take the stage, I'd like to turn things over to Victoria Sheffield, the Vice President of the International Agency for the Prevention of Blindness, for a few minutes. Victoria?
Mitchell, am I going first?
Yes, you are.
Okay, that's switched, all right. I'd like to pull up my slide deck. Let me share my screen. First of all, I'd like to thank the sponsors. We have 18 sponsors for this event, all members of Vision 2020 USA and Alliance for Eye and Vision Research, American Academy of Ophthalmology, Association for Research and Vision in Ophthalmology, Bright Focus, KCI Institute, Eye Bank Association of America, Flown Eye Institute, I hope I said that right, Helen Keller International, Himalayan Cataract Project International Eye Foundation, Kellogg Eye Center, Lions Clubs International Foundation, Moran Eye Center, and you're probably reading faster than I can speak, Pacific University College of Optometry, Prevent Blindness, Save-A Foundation, Southern California College of Optometry, and University of Colorado Department of Ophthalmology. I'm very grateful to Mitchell and Vision 2020 to give me a few minutes to thank, I want to thank them, but giving me a few minutes to talk about the Vision 2020, the Right to Sight program initiative, which has been going on for 20 years. And this is our anniversary, our 20th anniversary. We were meant to be in Singapore this week celebrating all the achievements of the initiative. And Suzanne Gilbert is on the line here. I can see she's the chairman of IAPB North America. So we're all meant to be celebrating, but we look back in 1999, where would the blindness rates be if we don't do anything? And we were looking at nearly 80 million people blind, but if we had some initiatives in place, we would hope to be in the area of 20 million, even going down from where we were in 2000. So the Vision 2020, the Right to Sight initiative was launched in 1999 by IAPB at WHO in Geneva. And we wanted to have a world in which nobody is needlessly blind or visually impaired, and where those with unavoidable vision loss can achieve their full potential. Over those 20 years, the World Health Organization passed 3 resolutions and launched the Global Action Plan in 2013. The plan was for 2014 to 2019. So WHO at their World Health Assemblies were very much committed and very much involved. What did we do? Well, in 2004, our data were 45 million blind, 269 million with low vision, and a total of 314 million. By 2015, the Vision Loss Expert Group is telling us that we estimate 36 million blind, 217 million with low vision, and 253 million totally visually impaired. That's gone down about 60 million in a world where the population is growing and aging. The Vision 2020 initiative said that we will focus initially on the certain diseases that are the main causes of blindness and for which we have proven cost-effective interventions. And the first one, of course, was trachoma, the leading cause of blindness for millennia. Are now, and the ancient Egyptians knew about trachoma. It is now less than 1% on the pie chart. The key stakeholders are WHO, IAPB member agencies, the International Trachoma Initiative, and Pfizer for its donation of azithromycin for mass distribution all over the world. Blinding malnutrition caused by vitamin A deficiency, the key stakeholders, WHO, UNICEF, Food and Agriculture Organization, and IAPB member agencies, of which there were over 150, the International Vitamin A Consultative Group, and then DSM, the successor to F. Hoffman LaRoche, for their wonderful donation of high dose, 200,000 international units, vitamin A capsules for mass distribution. And finally, onchocerciasis, parasitic disease mainly in Africa and Latin America. 5 countries are now onco-free by the World Health Organization. So the African Program for Onchocerciasis Control and its predecessor, Onchocerciasis Control Program in Ouagadougou, Burkina Faso, West Africa. These were programs funded by WHO programs funded by the World Bank. And then, of course, the major donation of Mectizan by Merck & Company for as long as it is needed. And I'll be showing you the pie chart in a minute. Well, there it is. So looking at a pie chart, trachoma is less than 1%. Vitamin A deficiency and onchocerciasis don't even show up on the chart. Cataract is now 35%. Basically, before 2011, it was over 50%. Then it went down to under 50%, about 47%. But with the introduction of uncorrected refractive error there in the pie chart, cataract is now at 35%. But we've done well. The World Report on Vision was launched last year on World Sight Day, October 10th. It's directed at ministries of health, and ministries of health and governments have to report on what they're doing for eye health services and how they're improving and expanding. And it's tied to the UN Sustainable Development Goals, mainly 3.8 for universal health coverage. It says that 2.2 billion people in the world are visually impaired. 1.2 billion have received services, including me, who I wear glasses, but 1 billion are still needing treatment or are blind because of avoidable conditions. So that's the gap we have to close. And finally, the IAPB Vision Atlas 2.0 is being launched today, and I encourage you to go to www.iapb.org and look at the Vision Atlas. You can get data from all over the world, looking at diseases, looking at health services, and it's all there on your iPad. So thank you, Mitchell. I really appreciate it.
Thank you, Victoria. That was a wonderful presentation, and it's really incredible what's happened in the world of vision over the last couple of decades. A lot more work to go, and I think we're on to one of the solutions to the future challenges with our discussion today. So now I'd like to introduce Dr. Tony Cavellerano, who joins us as the former director of the Veterans Health Administration's Asynchronous Training Center and an adjunct professor at the New England College of Optometry. Dr. Cavellerano participated in the initial validation studies for telehealth as a means to detect potentially blinding retinopathy from diabetes. Dr. Cavellerano has lectured nationally and internationally and published extensively on various ocular diseases, technology, and telehealth topics. Tony?
Thank you very much, Mitch, and thank you to the entire World Sight Day team for inviting me here today. It's a pleasure to be with all of you, and as well as my colleague, Dr. Zimmer-Galler. She and I, it's been a long time, but we certainly go way back in the era of telemedicine, and certainly appreciate the opportunity to work with her again after so many years. So, share my screen, and what I'd like to do today is to present to you sort of an overview of telemedicine, where we came from pre-COVID and where we're going after COVID. And Dr. Zimmer-Galler will pick up on the conversation in a little bit more detail. Get this out of the way. I have no relevant or irrelevant financial relationships, as a matter of fact. Let's take a look at telemedicine because it's really come into its own. And I believe that telemedicine is, even before the era of COVID, is incredibly important in terms of patient access. Certainly for remote care. And we know that almost a quarter of the US population lives in some type of a rural or highly rural setting. But access to care may not have anything to do with geography. There are many, many barriers to care, cultural, geographic, of course, economic, lack of understanding. And the biggest one is lack of access, especially for individuals with chronic disease. And certainly in the era of COVID-19, we've seen a major uptick, as you'll see, in the application of telemedicine programs and platforms. And another aspect of telemedicine that I really like to emphasize, and I firmly believe is important, is patient education and adherence. Some of the early studies are already showing that there are fewer missed appointments, and there's much better adherence not only to appointments, but also to treatment. And certainly we know in eye care, treatment for conditions like glaucoma and diabetes in terms of monitoring blood glucose control and adhering to recommendations for regular and timely eye exams is not as consistent as we would like it to be. So let's take a look at for telemedicine to really work and for telehealth applications to work, the two important ingredients are information technology and electronic health records, which really are a subset of that. And I think Steve Jobs had the right idea when in 2007, he introduced the iPhone. And certainly we know that in the palm of our hands, that's revolutionized everything that we do. And we know that in the United States, almost 100% of the population owns mobile phones. And even abroad, it's surprising in some of the third world countries, the number of individuals with mobile phones. But here in the United States, more than 80% actually own smartphones, which are incredibly valuable when we're talking about telemedicine. There are so many wearable technologies now that have come on board just since Web 2.0. And a lot of Web 2.0, as you know, has to do with user content and social media. And the timing was exactly right. With telemedicine and technology, medical images are digitized. We can do real-time audio and video, certainly. And again, patient education is a very important component of what we all do. And the other advantage of some of the technologies is adaptability, portability, and affordability. Everyone who has a smartphone knows what the potential use of that device is and how many different applications exist just in the palm of our hand. And I think one of the things that we're getting used to very quickly is the fact that these devices are not only portable and affordable, they're also reasonably accurate. The resolution that we can obtain from some of these devices, for example, an echocardiogram device for use in the home, or importantly for us in the eye care arena, fundus photography and slit lamp examination are now becoming more and more available with the application of smartphones. And we're seeing not only outside of the office, but even in the office, a lot of these devices are so easy and portable and so acceptable to not only the providers, but also the patients that they've really made a great advances in terms of what is applicable in the clinical arena. You know, telemedicine didn't just begin with COVID-19. As far back as the late 60s and early 70s, we had in the late 60s, Boston Logan Airport created a telemedicine bridge with Mass General Hospital and Logan International Airport. in the 1970s, the StarPack program, which was a NASA space technology program initiated by NASA to provide care and service to the Papago Indians living on the reservation. But really, it was the NASA manned space program in the early 60s rather, starting with the Mercury program and going all the way up to the Space Shuttle program, where NASA was keenly interested in the effect of weightlessness on astronauts, but also other important vital signs that needed to be monitored while the astronauts were in space. It was certainly a new frontier. No one knew what effect it would have on the human system. And via telemedicine, certainly there was a lot that could be done even in the very primitive stages of telemedicine. You know, technology has been not only a bane of many people's existence, but also provides opportunities for us. And having worked in telemedicine for many years, as Dr. Zimmer-Galler has, it was very slow in coming. We had a lot of convincing to do at the very beginning. And certainly, I think we were just about at the tipping point here at about 16% before COVID stepped in. And now we very quickly went from, you know, the early adapters, early majority segment of Rogers diffusion curve to something totally different. The CMS data for fee-for-service telehealth encounters in February of 2020 was less than 1%. And you can see where it catapulted to a mere 2 or 3 months later. By April of 2020, 43.5% of primary care face-to-face primary care fee-for-service encounters were taking place via telehealth. And it's only gone upward since then, and we can expect that it's going to go even further as time progresses. And as I mentioned, you know, they break down barriers to care, and patient acceptance, from my experience, has never really been an issue. It's really been more of provider resistance to the technology in telehealth, but that changed very quickly. And as Dr. Brinks mentioned, it's impressive not only with society, with education and learning, and with healthcare, how rapidly we pivoted to an almost entirely virtual type of environment, certainly temporarily, and I hope moving forward. And you can see the modalities that exist. This is just a random example of almost 30 telehealth applications that are available within the VHA system. And this happens to be one at the Cleveland VA Medical Center. It's certainly not exactly representative, but certainly most VA facilities have many of the telehealth modalities that you see listed here. In essence, there's 3 types of telehealth modalities. Probably the first one to come along is the home telehealth, or the so-called telecare modality, where patients are given devices to use in the home, typically for chronic disease, COPD, diabetes, asthma, obesity, where patients can actually obtain data on their own and transmit that data to a repository, a reading center, where an independent licensed provider will review those data and on a regular basis communicate with the patient as to whether they should maintain the course, whether they should make changes in their treatment, whether they need a visit, whether they need a face-to-face visit. So home telehealth has really made extraordinary strides. The devices that are available, again, having access to smartphones and tablets, has made the process extremely amenable for both patients and providers alike. And we also have, when we talk about eye care, opportunities to do home telecare with eye care devices. For example, there are now devices to monitor age-related macular degeneration, especially type of degeneration that can cause sudden or acute vision loss. Oftentimes, patients may be at high risk for vision loss from macular degeneration the neovascular variety, and not even realize it. With some of these home devices now that are gaining entry into the healthcare system, patients can actually self-monitor and be more aware of, and also it serves as an educational opportunity, an educational moment for the patient to determine if they are at immediate risk of vision loss, because we have now targeted treatments which can be directed towards these acute phases of age-related macular degeneration and other forms of diabetes that can actually preserve vision, which of course is our ultimate goal. And in addition to home telehealth and telecare, we have clinic or office-based telehealth. And there are two main varieties of clinic or office-based telehealth. One is real-time or clinical video telehealth, and the other is asynchronous, or formerly known as store and forward telehealth. Let's look at clinical video telehealth first, because clinical video telehealth is an opportunity for individuals working with either a healthcare assistant or a telehealth presenter to communicate with a provider, typically a specialist or a physician at a distal site, to provide and render care, especially in remote areas. Now, specialty care also is in great need in urban areas as well. If anyone's tried to get a dermatology appointment, a medical dermatology appointment anytime recently, you realize how long the wait is. And dermatology was one of the disciplines that actually lent itself to both types of clinic or office-based telehealth, namely the real-time telehealth as well as asynchronous telehealth. And our goal of preserving vision is critical, and we know that the top four causes of vision loss are critical, but mainly can, in many instances, be treated if patients have access to care. And we know that vision loss is also one of the top four causes of loss of independence in our society. And the economic burden, along with Alzheimer's and related dementia diseases and hip fractures, really account for an enormous socioeconomic burden. Vision alone accounts for $139 billion to the U.S. economy. And we know that these numbers are only going to grow as the population ages, as Victoria already mentioned. And almost half of these costs are direct medical costs. So anything we can do to preserve vision and to protect the patient from severe vision loss goes a long way, not only for quality of life for the individual, but also for society as well. The leading causes of blindness worldwide, and certainly in the United States, in the United States, certainly we know that cataract, for example, is a treatable cause of vision loss, although it certainly affects a large percentage of the population. But diabetes remains one of the leading causes of vision loss in the working age population. And that's unfortunate, because early treatment and access to eye care and medical care can actually reduce the risk of severe vision loss to probably around 1% per individual, assuming they can seek the appropriate and timely eye care that's required. And one of the areas where clinic-based telehealth really took hold was in the area of asynchronous or store and forward screening and evaluation for diabetic eye disease. And both Ingrid and I were involved in some of the earlier work that took place related to diabetic retinopathy. And one of the reasons diabetes lent itself so well to evaluation via remote care was it had already been a diagnosis of level of diabetic eye disease had already been validated by the early treatment diabetic retinopathy study and the diabetic retinopathy study before that. And because of that, we were able to, on a lesion by lesion basis, validate technologies and telehealth systems that could actually characterize populations and stratify people into an eye care program. and along with that, we make an assumption that everyone with diabetes needs an eye exam. The question is, when do they need it? Do they need it next week or next year? And because of the burden of many, many eye clinics throughout the country and access to care because of capacity, even pre-COVID, offering the opportunity of remote care via store and forward telemedicine at least allows the opportunity to evaluate the patient and determine and stratify the population to determine how urgent it is for that individual to have an eye exam. Along with that, and as an outgrowth of the diabetic retinopathy study, we began to look at other conditions like age-related macular degeneration, and even to a lesser extent glaucoma, which is a little bit more subjective in terms of making determinations via telehealth. But we certainly didn't want to. We wanted to take advantage of the platform that had already been established. So in the early 2000s. We undertook a joint study with the Joslin Diabetes Center, the Veterans Health Administration, and the Department of Defense to determine if it was possible to validate a clinical pathway using non-mydriatic or undilated retinal photographs taken by a naive technician who's trained and certified to capture images using a standardized protocol. And some of these protocols differ. For example, the protocol here in the U.S. is a little different than the EuroDiab study and DIAB program, and a little different than other studies. But certainly, it was a way to access patients who did not have an eye exam for a year or longer, and who were coming in for an exam, for a prescription refill, for a mental health visit, or a podiatry visit. These patients were accessed and their images were captured. They were reviewed by an independent licensed provider, and a report was sent back to the technician, who would then prioritize the patient into an eye care program. And this program really began in earnest in the VA in 2006, when congressional support mandated that we provide screening for veterans throughout the entire U.S. And in the first 12 years of the program, we imaged and diagnosed level of retinopathy for over 2 million veterans. And that's 2 million unique veterans. If you count those who were re-imaged for various reasons over time, it was even a higher number than that. And we thought, what a great way to characterize a population and determine what the risk of progression is, and also how could we relieve the burden of the eye clinics throughout the VA and DoD system, which are already overwhelmed with patients coming in for a myriad of problems, including refractive errors, including myopia, including glaucoma, injuries, inflammation, and so forth. So what we did was we took a look at the first 1,219 patients that we imaged at the Togus VA Medical Center in Togus, Maine, to see if we could, again, characterize this population. And what we found when we published our data was that almost 80% of the patients that we imaged had either no retinopathy or very mild diabetic eye disease, meaning that these individuals need an eye exam, but their eye exam can take place in a year or maybe even in 18 months, assuming they have no other problems. Now, these data are a little bit misleading in the sense that the almost 80% refers specifically to diabetic eye disease. But in the course of our asynchronous program, we also identified patients with other conditions, with retinal vascular conditions, with suspicion of glaucoma based on the appearance of the optic nerve, macular changes. So these patients were then referred appropriately by the image reviewer according to other information in the medical record. Certainly the technician would capture a brief history from the patient, and sometimes it was just the history that triggered the referral. And so what we did with that data was we took a look at the next 5,400 patients that we encountered. Again, these were just consecutive patients. And again, we found very similar findings that approximately 80 or a little bit more than 80% had no diabetic, evidence of diabetic retinopathy that required immediate referral. And again, that doesn't mean these patients didn't need to be referred for another reason. Sometimes it was because they haven't had an eye exam in 7 or 8 years. So what we decided to do was we took this information and this platform, and we tried to apply it to age-related macular degeneration, and certainly, not trying to steal any of the thunder from Johns Hopkins, who certainly is a leading institution for diabetic eye disease, but also at the Wilmer Eye Institute for age-related macular degeneration. But we created a standardized method of image review so that we could even further identify patients and stratify that population related to macular degeneration. And we published that data as well, and again found that although these patients may have had other comorbidities related to their eyes and vision, about 75% had no apparent abnormalities that required immediate referral. Again, not only is this informative for the patient and reassuring for the provider, but it also, again, relieves some of the enormous burden that the eye clinics have based on other conditions that are treated typically in an eye clinic. And then we looked at optic nerve, and as I mentioned, it's a little more difficult to make determinations objectively. We don't have lesion by lesion findings in glaucoma that we have in diabetes, and to a lesser extent age-related macular degeneration. But certainly we're able to use the data captured from the appearance of the optic nerve to make informed decisions about whether that patient needs a referral. And I might add that a certain percentage of patients for diabetes, macula, and glaucoma or optic nerve have ungradable images. That means the images could not be appropriately reviewed by the reader. And that triggers an automatic referral, not necessarily immediately, but certainly in less time than a year. And if you look at, again, based on access, if you look at the percentage of patients who were referred strictly for diabetes, macula, and optic nerve, you can see that in all three cases, it's less than 7.5%. And that was an enormous benefit to eye clinics throughout the VA and elsewhere, because a lot of veterans seek care outside of the VA, thanks to the CHOICE program and other programs that have been initiated for veterans care around the country. So I think that very nicely explains some applicability of one telemedicine and telehealth application to provide connected care to patients who otherwise may not have access or have limited access. So I guess we ask the question now, where do we go from here? And what will it take, apart from a disaster or a pandemic or some other catastrophic event, to really make telehealth and connected health a sustainable and scalable approach to delivering healthcare? Because any approach to quality or any initiative to quality of healthcare is going to have to involve information technology. And in order for it to be sustainable and scalable, we need, in my opinion, we need to have a universal health record, so that if you're in Washington, D.C. and seeking care in Portland, Oregon, your information is retrievable by your provider in Portland, Oregon. We need expanded licensure. We need reimbursement parity, incentivized providers, and standardized training and certification for the end users, so that the data that we obtain can actually be used by payors and by insurance companies and by others to make very informed decisions about the direction of healthcare moving forward. So the universal EHR, certainly a big help. We need licensure and legislation changes in order to effectively allow providers to deliver care across state lines, especially for those who live in the border areas of states. And we need something more than compact legislation, which now has been a big help in terms of relaxing some of the stringent requirements to delivering care across state lines. But we need more formalized type of licensure and regulatory changes. Telehealth parity for reimbursement, a very critical aspect of the sustainability and scalability of telehealth. Providers need to be reimbursed in order for this, for telehealth to really be as scalable as we would like it to be. There's a certain cost to delivering this care, and I think initially the cost may be a little higher, but I think over the long run, we're going to see that the cost of delivering care, the improved outcomes, the fewer hospitalizations, the more patients that we can preserve vision for is going to go a long way to helping to add to and relieve the socioeconomic burden of vision loss and loss of independence. And finally, we need some incentive for the capital investment that providers have to make for all the devices and equipment. And this includes maintenance and support. Devices, a provider can pay as much as 15 or 16% annually of the capital cost of a device for maintenance, upgrades, and software refinement. So we know that it's formidable, but we also know that it's possible. And finally, the future we know is unlimited. Everything we've talked about so far, credit card chips, universal EHR, augmented and artificial intelligence and virtual reality are making inroads. We know that even now we have 2 FDA approved systems for evaluating diabetic retinopathy using automated image interpretation. And we also know that virtual care is also taking place in hospitals. In St. Louis, Mercy Virtual Hospital consists of a facility where there's over 300 healthcare providers rendering care and monitoring thousands of patients remotely, in addition to the in-person care. So certainly telehealth and telemedicine is here to stay. It's a viable alternative to care. From my experience, patients have embraced it over the years, and I think providers have begun to embrace it as well. And I do strongly believe that telemedicine is here to stay. So I again want to thank World Sight Day and Dr. Brinks for including me in this presentation. And right now, I'd like to turn the program back over to Dr. Brinks and Dr. Zimmer-Galler. Thank you.
Thanks, Tony. That was a really terrific presentation, very informative and insightful. There's a lot to learn in this field. Now let's take a few minutes here to hear from our second speaker, Dr. Ingrid Zimmer-Galler, who's spent 26 years at Johns Hopkins University, primarily pursuing academic interests around telemedicine. And actually, earlier in her career, she was instrumental in setting up one of the earliest large-scale diabetic retinopathy screening programs in the U.S. She was the founding executive clinical director of telemedicine for the entire Johns Hopkins health system and building the infrastructure that allowed the institution to almost instantaneously ramp up telemedicine in response to COVID-19. Dr. Zimmer-Galler recently retired from the university to move into private retina practice, where she continues to develop telemedicine with the American Academy of Ophthalmology, and she also serves on the World Health Organization's Digital Health Roster of Experts. Ingrid?
Mitch, are we, is the time going to shut off at noon? I'm just asking in terms of, if we'll have time for questions?
I think we can stay over a few minutes. I think that's possible. It'll be up to the listeners, but I think that's very possible given the technology. We have time to wait. So feel free to deliver your full presentation, and we'll take time after that for Q&A. Thanks, Ingrid.
All right. Well, thank you also for including me with the Vision 2020 USA program for World Sight Day. I'm really excited to be able to participate And I'm going to talk a little bit more to follow up on the excellent presentation that Tony just gave. I have no financial disclosures. We live in truly extraordinary times. We're seeing a convergence of forces that is disrupting and transforming traditional medicine into a new medicine. And telemedicine is certainly at the forefront of that convergence. There are numerous benefits to telemedicine, and very briefly, I'm just going to run through some of these. There are obviously financial benefits that include direct revenue, but also indirect revenue, as telehealth allows us to obtain new patients, retain patients, and lose less patients to other areas that offer telehealth. There are operational efficiencies that can improve finances. And a big thing to look at is how telemedicine can actually help us with cost avoidance. We can now take lower acuity cases and provide less expensive types of care, leaving the higher acuity cases to come in for the in-person visits. There's also a lot of value to be had from telemedicine. That includes the patient access, patient convenience, provider satisfaction. Clinical quality is also greatly benefited because with telemedicine, we can now connect with patients across the continuum of care from outpatient to inpatient settings. I'd like to show a couple of different predictions. So in 2019, prior to the pandemic, the trend for telemedicine adoption was rapid growth, but overall still very low volumes. And widespread adoption really was contingent on coverage expansion. And the main challenges that were thought to be unaddressed with telemedicine, by and large, all revolved around reimbursement. It's difficult to provide a service if there is no payment for that service. Last year, the predictions for telehealth volumes in the United States were that about a third of primary care visits and almost 80% of behavioral health visits could be performed with telemedicine. And the prediction was that that would equate to roughly a $30 billion telehealth market. And at that time, really, when we look at where we were with, I'm trying to use the laser pointer here, but where we were a year ago in telehealth adoption is probably somewhere between the early and moderate stages of adoption. And so there's a number of key drivers for telemedicine. Certainly the technology is here and it's begging to be used to increase digital health in a variety of ways. Health system transformation is increasingly relying on alternative models of healthcare delivery. And sorry that this is popping up here. And then we also have consumer demand. And really the consumers, the healthcare consumers today are changing, and they expect convenience, affordability, and quality. And that's redefining on how they engage in their care. Younger consumers are not satisfied with the healthcare status quo, and they're more willing to seek out non-traditional services. So the healthcare consumers today want convenient care, they want urgent care, and they want telemedicine care. So when we go back to the key drivers, if we have all these things pushing telemedicine forward, what's keeping us from adopting telemedicine? Well, the key things, as you already heard in large part discussed by Tony, policy is a big issue, and also financing. Again, if there is no payment for a service, then it's very difficult to provide that service. So now we have COVID-19, which really was a tipping point for telehealth. And it's estimated now that instead of the earlier predictions from a year ago, it's estimated that there will be 1 billion telehealth visits in 2020. That's in spite of the fact that in January, only about a quarter of all healthcare organizations even had a virtual health program in place. There are numerous benefits, of course, that come about with telehealth during the pandemic. For patients with COVID, telehealth allows providers to assess their symptoms and their needs without actually bringing them into a clinic unless it's absolutely necessary. For non-COVID patients, during the early parts of the pandemic, the only way that these patients had any access to providers was through telehealth. And that allowed them to see their providers and not risk exposure. And then for clinicians, of course, the benefits are that they were able to connect with their patients without risking exposure to the virus. And and providers who actually had COVID or were quarantining because of possible COVID were still able to continue to see patients if they did that with a telemedicine platform. So the reason that telehealth was able to move forward so rapidly during the pandemic was in large part because Medicare restrictions that were keeping telehealth from moving forward were relaxed. And when Medicare relaxes restrictions, other payers usually will follow. And some of the key things that they relaxed is that virtual visits were now allowed to be conducted from home. Video platforms could be used that patients are used to, such as FaceTime and WhatsApp. These are apps that don't meet the HIPAA requirements, which are being waived during the pandemic. This requirement is probably the first requirement that's going to go once the pandemic is over. Other things that were very helpful for telemedicine are that audio only or telephone visits are now reimbursable, and it's possible for a patient-physician relationship to be established by telemedicine. In other words, you don't need, there is no longer the restriction that you need to have established a patient-physician relationship in person before using telemedicine. So what are the real predictions now for 2020? Instead of a $30 billion telehealth market, it's now estimated that in 2020, we are talking about a $250 billion market. When we look at what happened at Hopkins, this is again a great example of what the pandemic, how it jump-started telemedicine. In February, in the months before the pandemic, Hopkins was doing about 500 telemedicine visits a month. By mid-April, that number was up to 5,000 telemedicine visits a day. And when we look at the areas where telemedicine was being used, really every specialty, every department at Hopkins has now embraced telemedicine and is using it in one form or another. So what about ophthalmology? Well, ophthalmology is a highly visual specialty. Most of our diagnostic testing is image-based. And the beauty of all this is that the examination, even though it requires special instrumentation, most of that instrumentation can have a camera attached to it so that you can obtain more images that can be looked at. And so ophthalmology is actually a specialty that's that is optimally suited for something like teleophthalmology. There are significant challenges for ophthalmology due to COVID. If nothing else, we have to consider that it's impossible to maintain social distancing when doing an in-person eye examination. If you're doing a slit lamp exam or an indirect exam, as you can see, you're really right up in the patient's face. There are now plastic shields and barriers that can be used, but again, it's very difficult to do an in-person ophthalmology exam and maintain social distancing. Traditional clinical workflows usually include things such as overbooked schedules, long wait times, packed waiting rooms, and patients interact with numerous staff during a visit. And these are all things that during COVID, of course, are no longer something that's accepted or possible. And so the new reality is going to look at things, emphasize things such as symptom screening, temperature checks at the door, patients waiting in their cars or outside, lighter schedules to maintain that social distancing, and of course, increased sanitation measures. But this brings us again an opportunity for teleophthalmology. We have a very long and rich history of telemedicine in ophthalmology, and you already heard about a lot of that from Tony. Diabetic retinopathy assessment really is kind of our flagship ophthalmology telemedicine offering. There are equally robust and widespread programs in place for teleophthalmology retinopathy of prematurity screening. And then there are many other programs that are on a smaller scale, but also utilizing teleophthalmology. The one area where eye care has been a little bit behind is in virtual video visits. And part of that is because of the challenges of being able to examine a patient using slit lamps and indirect ophthalmoscopes. You obviously can't do that with a video visit. But there are many opportunities. There are many types of eye problems, eye issues that can be evaluated with a virtual video visit. And I'm going to just give a couple of examples of that in a moment. What we're seeing in retina quite frequently now during the pandemic is what's called hybrid teleophthalmology. And roughly a third of patients that are being monitored with chronic eye disease would be appropriate for a hybrid teleophthalmology visit. And what this involves is a patient coming into the office to receive imaging, a vision check, and a pressure check. But these are things that can be done in a very short period of time, allowing the patient to come in and leave really in less than 10 minutes time. And this is then followed up with a virtual video consultation with the eye care provider. So this increases efficiency. It means that there are less patients in the office at any given time, and the patients spend a lot less time in the office. While this is probably being used more often in retina than in other specialties, it really has great applications also for glaucoma, cornea, and optometry. The other beauty of hybrid teleophthalmology that this is something that can ultimately be expanded to improve access to specialty services in underserved areas. Rural areas that may not have retina specialists or glaucoma specialists often will have general ophthalmology or optometry, and many of the imaging devices that we use are available in those settings. And so patients could have the imaging obtained in their local community and then have access to a specialist at a tertiary care center that's remote from where the patient is located. Another area where we have actually made great strides using telemedicine is with ED teleophthalmology consults. In the United States, most community hospitals do not have an ophthalmologist on staff, and this means that patients who need emergency eye care need to be transferred to another facility. So we have a clear mismatch of patients and resources in acute eye care problems. Now, when we look at the epidemiology of eye-related visits to emergency departments, we find that a significant number of these visits are not even true emergency visits. Also, out of the visits that are for emergent conditions, As you can see on the images here, very often these are problems that are on the front part of the eye, the anterior segment of the eye, something that you can see without any specialized equipment. The non-emergent conditions that bring patients to the ED, again, are things that are all on the anterior segment or the front part of the eye that you can easily see with imaging without requiring specialized equipment or training to use that equipment. So the program that we established was to use an existing telemedicine cart in a community hospital that has a high resolution handheld camera. And with that, it's possible to obtain very nice images of the front part of the eye. And the patient can then, in the community hospital, have a video visit with an ophthalmologist, and instead of having to be transferred to a tertiary care center, they can have their care in place. And this has allowed roughly an 80% decrease in the number of transfers from one emergency room to another. So again, there's significant avoided cost here with avoided transport, a second ED visit, and a second provider examination. And this is truly an example of how telemedicine can provide the right eye care at the right place at the right time. Another area where telemedicine can be very helpful in ophthalmology is with education. In ophthalmology, residents or physicians in training are responsible for call and for triaging at academic medical centers. And so really you're taking perhaps the least prepared individuals, residents that often are early in their training, and you're asking them to take care of patients that may potentially have some pretty complex problems going on. By integrating telemedicine into the ED for resident education, that not only improves education, but it increases the accuracy of diagnosis, it shortens the length of stay in the ED, and certainly it increases patient satisfaction. And the way that the system was set up is basically to have a fundus camera in the ED. And so this is a type of asynchronous or store and forward program, but patients that had eye symptoms that were appropriate for fundus imaging would have an image taken of the back of their eyes, and that could then be reviewed by a senior resident or as needed by a faculty member, again, significantly increasing the chance of taking care of the patient right at that time, and also reducing the possibility of getting unnecessary testing, such as potentially MRI scans and things that would not be appropriate, but may be obtained if a resident doesn't know what's going on with a patient. I'm going to just spend a couple moments talking about robotics and telesurgery. This is something that is coming, and it's actually very exciting stuff. There are cooperative robots that basically assist the surgeon, that keep you from doing something that you shouldn't be doing. And then there are teleoperated robots that allow you to perform true surgery when the patient is at a remote location from the surgeon. And the reason that in ophthalmology this becomes very important is that the eye is actually a very small organ. The retina is only 250 microns thick, and the internal limiting membrane is only 3 microns thick. This is actually a structure that, depending on what the pathology is with the eye, this is a structure that we often have to peel from the surface of the retina. Again, we're talking about 3 microns in thickness. So this is surgery that is all done under a microscope, but we can significantly improve on what the surgeon is able to do with smart tools. These are basically tools that tools that are aided robotically. And for example, here you can see the human, the manual attempt to cannulate a retinal vein compared to what the robot-assisted version will do, how much more quickly and more steadily that can be accomplished. The first robotic vitreoretinal surgery was actually performed in the UK in 2016. And I think, again, this is something that we're going to see more of in the future, not just in ophthalmology, but in general surgery as well. So what are our expectations for telemedicine post-COVID? Well, one of the important things is that we can't silo telemedicine into some specific department. We really have to make it an enterprise-wide priority. The telehealth experience also has to be seamless. It has to be easy, both for the patient and for the providers. When you look at some of the statistics that are coming out from the pandemic, we find that a quarter to a third of video visits end up with some kind of technical difficulty. So in spite of really ramping up telemedicine, virtual video visits, there still are technical issues that patients and providers run into all the time. So again, the telemedicine strategy really has to be that it's an enterprise-wide priority, and this lets us take advantage of really the benefits of taking patients, again, through that whole continuum of care, where we can take care of them from an outpatient to an inpatient to a remote chronic disease management type of setting. So we know that telemedicine is going to be useful to expand the populations we serve. It's going to be very helpful to improve access to care. It clearly can lower the total cost of care, but we need to also keep in mind that telehealth solutions rely heavily on technology, and that's often out of reach for populations that are already underserved. So we need to make sure that as we implement telemedicine, that we don't increase disparities. So telemedicine is definitely here to stay. It's no longer just nice to have. It's really essential that we have telemedicine and that we use it. We can't think of it as a separate entity anymore. And this quote from our CMS administrator, I think really sums it up very nicely. And there's really absolutely no going back. Thank you.
Thank you, Dr. Zimmer-Galler. That was terrific. Really, really enjoyed hearing from you. Learned a lot. I think all of us did. We do have time for a few questions. I have a few sent via the chat function for both of you, Tony and Ingrid, if you don't mind staying on for a few more minutes.
Sure.
The first is along the lines of what you just mentioned, Ingrid. I guess one person wanted to know why we more often see telehealth systems more fully developed in single payer systems or otherwise relatively contained systems like the VA or kind of enterprises. Why does that happen, and what are the barriers to kind of wider use and kind of the general healthcare system?
So is the question why they're not being used outside of larger enterprises?
Yeah, what are the challenges to doing that, and why are they more commonly in larger enterprises?
So one of the big advantages of telemedicine in an enterprise-wide system, as we set up at Hopkins, for example, is that it's integrated with the EMR. The video platform meets all the HIPAA requirements, the security requirements. Large enterprises can utilize Epic, for example. It's very easy to launch a telemedicine program directly from within the EMR. I'm seeing more and more that EMRs that are being used in smaller practices are also having that capability built in. And it does become a challenge when you use a separate system for your video, for example, and then you still have to go back and document that and figure out how to integrate all of those things together. But more and more EMRs that are being used by smaller practices, even solo practices. My EMR, for example, allows me to launch a video visit and keep everything contained within the system. The other big barrier, of course, is the problem with reimbursement. And then as you also heard from Tony, we definitely have to keep in mind state licensure requirements. That's still a big barrier, even though some of that was relaxed a little bit during the pandemic. I think that's going to remain a huge barrier if you want to take care of patients that are not physically in the state where you have a license. Remember, medicine takes place where the patient is located, not where the provider is located.
Great. Tony, would you like to add something to Ingrid's comments?
Yes, Mitch, I think to that, I would add that within an enterprise system, it's a lot easier to generate e-consults, e-pharmacies, e-referrals, and so forth. Whereas if you're using a standalone system, then it is much more difficult. And the other thing is, I think for telemedicine to really be totally successful, in addition to those features, and Ingrid mentioned this, it's important that all of the devices that you use, the instrumentation, is DICOM compliant, and that it can actually transfer data through the DICOM gateway onto the EHR. And if you have standalone devices, it becomes really difficult to store images on one device and then another device, and then have some images on your accessible on your EHR. So I think those are all issues that make, say, a VA or DoD system much more amenable to a telemedicine program.
Great, thanks so much. Oh, sorry, Ingrid.
Oh, just I was also going to add the you can't forget the legal part behind all of this, and large enterprises are going to have the luxury of having a legal team that can help address any of the legal questions that come up.
Great point. Second question here. Do you know if anyone has analyzed the telehealth utilization data from the start of the COVID pandemic to see what kind of social economic status indicators have played in terms of who's been able to access telehealth over the past few months?
That is a great question. I'm sure that is all being looked at. I don't have the answer to that. But absolutely, the concern that telemedicine, telehealth, that may introduce new disparities, that concern is real. And while everyone has a smartphone, that doesn't mean that they have the data bandwidth on their smartphone that they can do a video visit, for example.
And that applies to other things, Mitch, that you mentioned earlier, namely with education and with learning, and disparities exist, and we're the hope is that this does not expand those disparities to the point where people become even less and less able to access the care that they so vitally need.
Great, thanks so much. Another question here for both of you. Are there unique challenges for using teleophthalmology with children, and are there commonly accepted strategies for addressing those challenges?
The good thing with kids is that they are so accustomed to screens already that they actually do pretty well with these types of visits. That's where you do have to make sure, though, that you have that you legally have all the protections in place. There's always a concern, especially with older children, teenagers, There's a whole level of legal things that come into play. In some states, at a certain age, parents don't need to know, don't have a right to know what their teenage children are doing from a medical standpoint. And so that brings in a whole slew of different challenges. So kids are more from a legal standpoint, something to make sure you have your ducks in a row. But overall, doing visits with kids, virtual visits with kids actually works really pretty well.
Okay, so another question here. Can you comment on what the perspective has been from providers and healthcare administrators on the downstream utilization benefits of telehealth? To providers like that idea, to administrators like that idea in terms of financial efficiencies? Or what's your experience on that front?
Well, I think they like the concept of, and certainly down the road, like any other prevention program, and this is not a prevention program per se, but I think it takes a little bit of time for the financial benefit downstream to be recognized. As I mentioned, the initial investment and the upfront cost of equipment, instrumentation, software, training, certification for the end users, and then maintenance are very expensive. But I think if you look at the studies that show there's reduced hospital admissions and readmissions, there clearly is of interest to us a way to preserve vision and to get people into an eye care program. So without a doubt, I think ultimately it will serve to reduce costs and at the same time improve quality. I think some of the studies show that there's going to be an increase in malpractice events as a result of telemedicine initially, but I think that will probably flatten out over time as well. And I think with more standardized protocols and more standardized training, that's less likely to occur, or at least can be mitigated.
And the other interesting thing that, the pandemic has kind of put telemedicine, the trial by fire. But one of the big concerns that payers have had all along, commercial payers and also Medicare and Medicaid, the reason that they haven't embraced, prior to the pandemic, that they haven't embraced visits at home is the concern that instead of using substitute utilization, in other words, replacing an in-person visit with a telemedicine visit, the concern is that there will be overutilization. And if we make it so easy for someone to reach their physician, are we going to have every little sniffle result in a virtual visit? And those statistics, I think, over the coming months, we'll be able to learn a lot more. Clearly, as Tony mentioned, if you have an opportunity to take care of a patient with chronic disease, if you can catch them with a video visit before they show up in the ED, clearly that saves you an awful lot of money, or before they end up with a rehospitalization. So there are absolutely clear-cut cost savings. I think the payers would still like to see that there's not going to be an increased or overutilization of these services.
Terrific thoughts.
And the argument, excuse me, one other comment, the argument about that, excuse me, it appears that telehealth and telemedicine actually allows for more patient engagement. And without a doubt, in the era of telemedicine and the pandemic, people have to be more engaged in their own well-being and their own healthcare. And certainly there's no better way to do it. And I think one of the things we kind of didn't really, or I glossed over, was not only education for the patients, but also for providers. Sharing information and seeking consultation using telemedicine applications can really make a big difference for providers as well as for patients.
And that's something else that for the first time, Medicare is actually paying for, there's reimbursement for provider to provider consults. And that's something that in the past, there was no reimbursement for that.
Great. I've actually enjoyed that benefit myself, talking to subspecialty colleagues about complex patients when I'm not at the tertiary care center. I think we'll wrap it up with a two-part question here. Basically, the question has to do with, what do you think will be the determinants of the future trajectory of telehealth as COVID wanes? We have a lot of new information. There's a lot of opportunity. What do you think will be the key determinants, or who will be the key influencers in whether we invest and take telehealth to its potential, or whether it wanes a little bit? And the second part of that question is, what can we do as a vision health community to help that trajectory go higher toward telehealth's full potential?
The first part of your question, so interestingly, as everything has opened up again, the number of telemedicine visits across the board, video visits, those have actually gone down in number over the past couple of months compared to the height of the pandemic in April, May, June. So I do think that the volume is not going to be as high as it was at its height, but I think patients are realizing how useful this is. In my retina practice, not a day goes by that that I don't have a handful of patients that are in their 80s or 90s that say, "Oh yeah, I had a video visit with my cardiologist yesterday." So even the population that we were that was perhaps the hardest to target because they're not used to this type of technology. Even that population is using these visits more and more. And I think a big key going forward is going to be to promote it. We have to promote how useful these visits are. You have to obviously save them for what's appropriate. Not every visit is appropriate for virtual care. But no question, we have to continue to promote it. We have to continue to work on reimbursement and parity. We have to ensure that some of the rules that have been relaxed, that continues, not necessarily the HIPAA rules. We don't necessarily think those should continue to be relaxed, but the other things, it sounds like CMS is going to continue to follow along the path that they've gone, but there's no guarantees yet. All the things that CMS has done to help telemedicine, none of that is yet permanent. So,
and a lot of it will be driven by the patient. Patient acceptance. Certainly, I think that there's no doubt that patients really embrace this approach to care, and not only the convenience, but we found at the VA even 10 years ago. To Ingrid's point about even the aging population, you might not think is quite as conversant with the technology. They actually are seeking it out because of the convenience. Remember, a lot of people have to rely on transportation from a family member or from a public opportunity. So this really, I think you'll see a lot of patient-driven response to telemedicine over the coming months, especially if the opportunities diminish for whatever reason, either because of reimbursement or other means. So.
Absolutely terrific presentation, Tony and Ingrid. Thank you so much for joining us, and thank you, Victoria. That was also incredibly important information on a global scale. And thanks to our sponsors, and thanks to all our attendees today. Really hope you enjoyed and your time here and learned a lot. And we'll make this video available at the Vision 2020 USA YouTube channel. We'll forward that to you shortly after this call. So thanks, everybody. Thank you again, Ingrid and Tony and Victoria. And thank you to Dean Beaumont for setting this up. Have a nice rest of your day.
Thank you, Mitch. Take care.
Thank you.
Thank you. Bye-bye.